And I'd like to invite the panelists for panel 2 to come on up. Dr. Brian Johnson, who's professor of psychiatry and anesthesia from SUNY Upstate Medical University. Dr. Hector Biaggi, medical director at Crouse Hospital, Commonwealth Place, the BMAC Clinic and Day Treatment Program. Monica Taylor, director of behavioral health services at Crouse Hospital. And Jeremy Klemensky, president and CEO of Syracuse Behavioral Health Care. Welcome, panelists.
Hi, everybody. Thank you so much for coming out. I'm Brian Johnson, and I'm going to try to be incredibly quick here. So, the website for our addiction medicine is drugzombie.com. If you go to drugzombie.com, you find everything from how to make an appointment to academic papers we publish. My mission is to use technology and science to change and transform the way addiction treatment is done, and I'm the pain speaker right this minute. So this is the original paper showing opioid-induced hyperalgesia. Every dose of morphine or diacetylmorphine, also known as heroin, gives pain relief, but it turns on the pain drivers. They overshoot. So here's a rat study, the first one ever, showing that as the rat is on diacetylmorphine day after day, it takes less pressure on its paw to make it squeak in pain. We do something called the cold pressure test. It's an ice water bath. You put your normal forearm in, you see how long you can hold it in. It hurts, so the quicker you have to pull it out, the more hyperalgesic you are. The average time for normal controls is 102 seconds. You can see the first two randomly chosen subjects here, 3 seconds, 10 seconds. The opioid exposure caused everything to hurt so much. Every diacetylmorphine or morphine helps, but overall your pain is getting worse and worse and worse. That third one, who's some poor 17-year-old girl who was just put on opioid maintenance, she's still 3 minutes. The last one is a man who had a 10-second time. We detoxed him. He took so much opioid with ibuprofen, he went into renal failure because it hurt so much. A week later, he was a 3-minute guy and his pain was gone. So detox helps. So here's a study that we're just about to send out for review. We noticed that opioids cause brain damage. They damage the pain damping system in your brain. And we treat this with the polar opposite of morphine or diacetylmorphine. It's low-dose naltrexone. It's a pure blocker, nothing addictive about it. About half the patients in this 100-subject case series refused to take the naltrexone. We had recommended 36% got to 1 month off opioids. When people did take the naltrexone, 80% got to 1 month off opioids. No one believes me. They think I'm out of my mind when I say we're going to detox you from morphine or oxycodone. Your pain's going to get better. But you can see after a month, 3% said their pain was worse. And then it was either the same or better for about half of all those people. And finally, so if you're not going to use opioids, how do you treat pain? Well, it's a matter of the patient has to work hard. The first thing, exercise and physical therapy. You know, if someone comes to us and they weigh 300 pounds and their knees are killing them, we don't say we're wizards, we give you oxycodone and snip snap, we fix it up. We have to work with them to lose weight, to exercise. Anti-inflammatory drugs like aspirin, but there are 10 different classes. Acetaminophen, low-dose naltrexone, detox. We're very successful at helping people with their pain. To get rid of the pain completely, you have to die and go to heaven, but it will get better if you come for treatment. How available are we? We're very available. We don't take anyone on for maintenance. So we treat you an average of 10 visits, and we discharge you. We're training about a third of the upstate medical students currently. Some of the ones who are on my service and some of my current psychiatry residents will be out at a table afterwards. We'll give you a card that has the drugzombie.com website on it. We can't be open the first week of February because I'm on vacation, but otherwise we take oceans of people in. There's not a lot of wait as long as we have enough medical students to see everybody.
Great. Thank you,
So-
Dr. Johnson.
Thank you.
Doctor, how do you determine if a patient is a good fit for this particular type of treatment that you offer?
Well, you can't lose anything to try detox and our kind of treatment that's very intensive in terms of psychotherapy. Everyone gets unique treatment. If you fail a number of times, maybe you want to go to a maintenance-based treatment.
Thank you. Next, we'd like to hear from Dr. Hector Biaggi.
Hi, how you doing? Can you hear me here? Yeah, my name is Hector Biaggi, and thank you for inviting me here. What I'm going to be doing is talking a little bit about what is addiction by itself. I also going to be reinforcing the fact that it is a medical illness, okay? It is chronic, and there is treatment for this condition, which is more or less actually very effective compared to the treatment of other chronic conditions such as diabetes and asthma. Now, how do you? Okay.
Go ahead.
Now,
Monica, you want to use it?
sure. So if you see this slide, basically, it's a chronic disease of brain reward, motivation, memory, and related circuitry of the brain. Now, this condition also leads to biological, psychological, and social manifestations that all of you may be aware by now. And once you develop the addiction, you are constantly trying to get reward and or relief of your condition from this situation. Now, if we go here to the ABCs of addiction, there are other five components that it's important to take into consideration. One of them is the inability to abstain from seeking out this substance. You have an impairment of the behavioral control. You have cravings or hunger for the medication. There is a significant amount of denial on the patients. And also you have a dysfunctional emotional response to day-to-day interactions with other people. Now, here is a slide of the brain, and then it's a reward pathway, okay? Now, in the brain, there are natural endorphins that you release, actually that the brain will release whenever you are having fun, and it's actually stimulated when you're eating, having sex, thinking of a nice piece of chocolate, thinking about your own childhood, your children. Everything that gives pleasure is mediated by this pathway. Now, when people begin to take exogenous opiates, it hijacks the system. So basically, you have on the right hand in the diagram, dopamine is a neurotransmitter that will be the messenger between these circuits. It will basically stimulate the ventral tegmental area that in itself will go to a nucleus accumbens, and from there will go to the prefrontal cortex. All of these systems are involved in pleasure. They are also involved in motivation. They're also involved in trying to determine the differences between having rewards or thinking about what the consequences will be of, taking a drug. Now, here is a comparison that shows the brain changes that you see in a PET scan by taking different medications. On the left column here, you have a control, people that are not addicted. On the right column, you have addicted brains. You can see on the right column all the way, when you have, where you have the colors, that if your brain is acting normally, you have enough dopamine receptors that is shown on the left column. Now, with chronic use of substances, there is a downregulation. That means that the brain is receiving so much dopamine that physiologically it needs to adapt and then will shut down the receptors to avoid being exposed to so much dopamine. There's a downregulation of the receptors, and then what you have is that when you don't use drugs, when you don't have the stimuli to produce more dopamine, then you will feel energetic, you will feel down, and then you will feel actually, very upset. Next slide. Now, opiate addiction is a medical problem. It can be treated effectively with medications, and also is a chronic problem. It is very similar to asthma, hypertension, and diabetes. Sometimes people think, if you are addicted to medications, all it takes for you is to stop, go through the withdrawal symptoms, and that'll be it. That's a wrong thinking. It's kind of like if you break your arm or you have pneumonia, then you just need to get away the substance and then you'll be healed. That's not the case with addiction. 60 to 90% of the people that go through withdrawal and detoxification will have a relapse during the first year. That's a high number. That is a high number. The best treatment for this condition is a combination with medications and behavioral interventions. Now, lastly, it is, in this slide, you have a comparison, and then you think, what is the compliance of treatment for substance abuse? If you think of compliance as being following the physician's orders and doing what the doctor tells you to do, which one of these conditions you think has the highest rate of medical compliance? And surprise, heroin addiction, 60% of the patients will follow what the physician will tell you.
Thank you, Dr. Biaggi.
One more slide.
Okay. Okay.
Now,
one more.
And here just is a basic summary of the medications available for treatment of addiction. You have methadone. It comes in a tablet, oral solution. Buprenorphine. You have Suboxone. The main difference between buprenorphine and Suboxone is that you have an naloxone component. It's a partial agonist of the mu receptors. And then also you have naltrexone or Revia that Dr. Johnson spoke a little bit about it. All of them are quite effective. I do have a clinic of Suboxone treatment, buprenorphine medication assistment treatment. I have 75 patients in the clinic, and I have to tell you that 95% of the patients that I start on Suboxone come every single day to see me. They come every single day to see me. That's a good way to keep the population within 410 South Cross, because with every visit, then they will be able to go to groups and have other interventions that will help them in their recovery process. Thank you.
Thank you, Dr. Biaggi. Okay, moving along to Monica. Monica, can you describe to us what type of programs and services Cross Hospital offers, please?
Yes. So at Crouse Hospital, we offer a variety of treatment services. On an outpatient level, we have medication-assisted treatment. As Dr. Biaggi mentioned, Suboxone is one of them, and we also have a methadone program, which I'll talk about a little bit more in a minute. And the other services that we offer on an outpatient basis is an outpatient rehab program, which is basically the most intensive treatment on an outpatient level, where patients come 4 or 5 days a week, and they're with us for 4 hours. They are provided a meal, they participate in group therapy, recreation therapy, and within that program we have some specialty services for women, pregnant and parenting women, and also individuals with traumatic brain injuries. Then on the outpatient treatment level, it's a little less intense, where patients might be coming any times 1 to 3 times a week for 75 minutes to up to 2 hours. And with that, we have also a variety of specialty programs geared towards women, older adults, adolescents, and also co-occurring, where somebody has both a mental health diagnosis and a substance use disorder. And also at that lower level, we do offer services for individuals with both substance use and TBI, traumatic brain injury. Another big component of Krause's outpatient services is the addiction psychiatry clinic, where we have a physician, a psychiatrist that works closely with our patients who do have mental health disorders. And then if we go to the inpatient side, we have a 40-bed unit called Commonwealth's Place. It is co-ed, but all the programming is actually done gender-specific. So while they're in the same building, men and women, but all their programming is actually separate. And in the hospital at Krause, we do offer a hospital intervention service. And what that basically is, if somebody is in the hospital for any kind of medical reason and a physician identifies substance use as a potential issue, then we do a bedside assessment right there to see if this individual could benefit from substance use services. We also offer withdrawal management. We have a unit within the hospital. It is a medical surgical unit where somebody can also receive withdrawal management. Although we heard earlier insurance is an issue, and so one of the things that is a downside is we can barely get somebody in who has opioid use disorders into a hospital-based withdrawal management. So that is typically for individuals who are using alcohol, where some of the medical conditions with the withdrawal, like seizures, really need to be medically managed in a hospital setting. I'd briefly like to mention that the hospital has a urgent care setting, prompt care, and at prompt care we offer SBIRD, which is a screening service where basically patients are being screened for at-risk behavior or possible misuse of substances, and we can then make referrals for somebody at that point as well.
Thank you, Monica. Are you done or no?
Oh, no.
Okay.
In terms of our admissions process, we do have what we call same-day access. So basically somebody in need of treatment other than the medication-assisted treatment, they can basically walk in 7:30 a.m. to 1 p.m. and they will be seen that day, and they will leave with a recommendation for treatment on that day. We do participate with most insurances. We also offer sliding fee scales. And in terms of the inpatient withdrawal management, you would access that service actually through our emergency department. I also would like to share some stats. We've already seen earlier slides that in a way showed similar trend lines, that right around 2011 there seems to be some changes, 2011, 2012. And when we look at the admissions at our services altogether, whether it's outpatient, inpatient, medication assisted across the board, what we saw in 2011 is that the primary drug of choice reported on admission was opiates was the number one. Up until that point, alcohol was actually the number one reported on admissions. And as you can see, basically the data here goes back to 2004 and all the way up to 2015. It's quite significant, that number. Now, admissions, they could be, one person can have more than one admission per year, so these are not unique patients, these numbers. But in 2015, 52% of all our admissions had a primary diagnosis of opiates. This slide also speaks to this trend. This is data basically from 2000 to 2015, and what we saw is out of everybody that was admitted for an opioid use disorder, heroin was their number one, and there was an 800% increase in that. This compares some of our data from 2010 to 2015, and this is specific to our methadone treatment program. So in 2010, we had a total of 156 admissions, and in 2015, that was 256, so it was a 64% increase. And what is interesting is that the age range 26 to 35, that's where we saw a drastic increase. So you see in 2010 there were 65 individuals in that age group, and by 2015 that was 135. The other area that I'd like to highlight is that we've seen a drastic increase in pregnant women asking for admission to the opioid treatment program. I'm gonna skip this. In terms of treatment with methadone, it can only be provided in a clinic that is certified. You might hear that a pain clinic might use methadone, but they would only use it really for pain management. So in terms of addiction treatment, that can only be done in a clinic that is approved by the state. And it's important to know it's not just about the medication. I mean, people come to the clinic daily and there's a very thorough assessment. People receive counseling services and all kinds of social supports, because the goal is that we restore somebody's ability to live a self-directed life again. And sometimes we're being asked, how come it takes so long to get somebody into the program? How come you can't get that program filled up quicker? And there is a lot that is involved with an admission to the methadone program, and there's an induction phase that takes probably 2 to 3 weeks for most patients, and during that time they have to be seen daily by a nurse and have to be assessed for symptoms to determine if they are on a therapeutic dose. And this is, as you can imagine, rather involved. And in addition to that, anybody coming into the program does receive a very thorough medical workup. All of that contributes to, our inability to admit faster than we are. It is noteworthy, I think, to note, that we did admit 256 individuals last year, which I think was quite phenomenal. We have a great treatment team. This last slide I wanted to show, because methadone programs are not readily available throughout New York State, one of the things that we deal with is that our patients come from 18 different counties. And with a modality like methadone, where you have to come daily, for somebody to travel an hour or hour and a half to come to the clinic for the medication is a huge commitment. And what you can see in this slide is basically, I don't know if you can see the red numbers. So the red numbers show where our patients, what counties they reside in. And 70% of them are right here in Onondaga County. But as you can see, we have patients up in Jefferson County, Oswego, in the Utica area. And then the green stars that you can see, they show where the methadone programs are in New York State. And as you can see, about 3/4 of them are in the 5 New York City bureaus and Long Island, and the other quarter of them are sprinkled throughout the state. Krause has been operating this program for 40 years at this point, and we have been the only program this far, and we are excited to hear that Conifer Park is opening a program later this year in our community, and we're hoping that other providers are looking to open programs up in the North Country and also towards Utica, where they really do need these programs as well.
Thank you, Monica.
Thank you.
Moving along to Jeremy. Jeremy, can you give us an overview on the programs and services that Syracuse Behavioral Health Care offers?
Yes, certainly. The first thing I want to share is that if you're here tonight because you're trying to learn more about this treatment system that Monica and I are trying to give an overview of, I want you to know that there's hope. 25 years ago, I sat in a room like this, desperately trying to find hope for someone I cared about and loved very much in my family. And it took me a while, but I eventually did find a program, and that person did get help, and that person's living a tremendous life today. That experience was formative in my life, and that's why I've spent the last 20 years trying to build treatment capacity in upstate New York. So I want you to know, if you're here tonight and you may need to borrow hope from our earlier speaker who lost her daughter. I was fortunate enough not to lose my brother, but there is hope and there is a lot of work going on. So I'm going to tell you a little about the community-based side of treatment. Monica shared an overview of the hospital-based system. We're fortunate enough in this county to have some of both. At SBH, we have medically supervised withdrawal and stabilization services, which are appropriate for people experiencing mild to moderate withdrawal. If somebody is at really high risk of withdrawal, they should go to a hospital emergency room, just so everyone here is clear about that. Medically monitored withdrawal and stabilization is for folks that have mild withdrawal and or a situational crisis. Maybe they are in recovery, but they're really having a hard time abstaining or have lost their housing or something else. That's an appropriate place for that person to go while we try to stabilize their situation and try to prevent that crisis from turning into full-blown relapse or some other catastrophic overdose. We have 50 withdrawal and stabilization beds, 25 in Syracuse and 25 in Rochester. We also have an inpatient rehabilitation program, and that's the thing that a lot of people mislabel like going to rehab. You'll hear people say 30 days. There's no such thing really as a 30-day program anymore, just so everyone understands. It's all variable length of stay today based on the needs of the patient, and that's true of community-based and hospital-based programs. But this is what people think of when they think of that, and we have 40 of those beds in Syracuse. And this is for folks who have now been stabilized, but there's a lot of evidence to suggest that they are not stable enough to survive and avoid dangerous relapse and abstain from use without living in a structured setting while they're receiving ongoing medical care, counseling, and other psycho and social rehabilitation processes. On the outpatient services spectrum at SBH, we recently integrated our substance use and mental health disorder clinic so that we can treat both things concurrently in a more integrated way. We have walk-in hours 5 days a week. Interestingly enough, we had a walk-in patient today in this clinic who walked in off the street looking for help. Later, while waiting to be seen, became unresponsive and had to be revived. If it wasn't for the community of providers here, so for example, once that person received Narcan injections and was stabilized, our partners in EMS and the fire department got that person to one of the local hospitals, and we don't know how she's doing tonight, but we hope she's doing well and will probably be part of this treatment system if we're all successful in convincing the person to do that. And that's why why walk-in hours are so important. If you're shopping for services or a clinic, you should be able to get services quickly. Treatment on demand is what we call it, and same-day access is another term. That should become an expectation and a standard in our industry. Psychiatric consultation, medication-assisted therapy, and intensity of services ranges. For some people, it's daily. For some people, it's weekly. For some people, it's continuing care over a period of weeks or months. And we have certified counselors that deal with addictions. We have all the alphabets you can imagine, MDs, psychiatrists, and psychologists, RNs, NPs. It takes a large team to really treat all of the medical needs of a person in recovery. From the residential spectrum, this is for folks that have now been stabilized, but housing is an issue as well, and living in a structured environment is a concern and a challenge. So we have these things called community residences. Most people call them halfway houses. And we have, 88 beds in Syracuse currently. And this is for individuals who really, really need a structured environment. And oftentimes are still involved in outpatient treatment or other support services. At a less intense or acute level of care, we also have certified supportive living programs. And that's for folks who are working to regain skills and strengths, go back to school, gain basic skills. Believe it or not, we have folks, somebody asked a question earlier tonight about what happens to folks that come out of incarceration. You know, what happens to them? Well, oftentimes they enter programs like this because if they began their use and it manifested in addiction at a very young age and they were incarcerated for a period of time, they may not have finished school, they may not have ever had a job, and they need a safe place to live that is supportive of their recovery, where treatment is available, where they can rebuild those skills and supports. So that's a big type of thing that happens in a supportive living program. We also have recovery services to provide support to folks who are no longer in an acute phase of care, but want to stay connected with folks, and there's all kinds of things that happen. It's currently open 4 days a week. We're trying to expand that. Currently in development are a whole host of intervention services and community-based, home and community-based services that we hope will be open in the near future. If you want to learn more, or if you're someone here that wants to be trained to work with folks, either as a counselor or in some other capacity, we have a training institute which can do that. Listed here are some of the different things we teach. And on April 6th up at Syracuse University at the Sheraton, there'll be a Central New York Behavioral Health Conference that we're sponsoring with a number of other partners to try to, the focus and purpose of that is to push for higher standards of excellence within the treatment system in our community. This is a list of other treatment services in our region. It's very important that you're aware of all of these things. Only a few of us are presenting tonight, but we want you to know that there are a lot of other places that you can go that have programs. And I just want you to know what you're looking for in a treatment program is that it is certified by the state of New York, by OASIS or OMH or somebody else, because they can be certified now by multiple entities. And also, you're also looking for what other types of accreditation might an organization have, just so that you know that they are qualified to be doing the work that they're purporting to do.
Thank you, Jeremy. You talked about a very broad spectrum. Can you tell or can you share with the audience in terms of the referral process and if there are, in fact, wait lists to get into any of your programs?
There are usually wait lists to get into programs, especially programs with beds, because the reality is the rise, the statistics you saw earlier for our county are a statewide problem. While the governor's budget has been very supportive of increasing capacity, unfortunately none of that money at the moment is targeted to Central New York. We're hoping that will change. And so yes, there are wait lists, but sometimes there aren't. What we tell people is call, get an assessment and a helpline done. The thing that's incumbent upon any provider like myself or Monica's programs is if you do an assessment with us, we have a legal obligation to try to help connect you with another level of care if we can't get you into our program. And so that's an important thing to be aware of, that just because you think there's a wait list or you may not be able to get in somewhere, that doesn't mean you shouldn't try. Because there are folks at our agencies that will do work to try to help connect you to somewhere else if we can't get you in. Also, those wait lists matter because our friends in government look at them, and it does affect sometimes their decision making about where resources are allocated around the state, and that's important.
Thank you. I have a ton of questions, but we're going to take some questions from the audience. Matt, are you live?
Yes, I am, Monica, thank you. We did have a very major theme related to access issues. Several people were asking access, so maybe just to reiterate, if you have any additional comments for any of the panelists. Particularly, one question was around young people and getting young people access. Maybe they don't want to go to a rehab and they don't access treatment. They end up with an overdose situation. And what happens if you have somebody who's ready and there is not a bed available, there is not access to an outpatient service? What can folks do in those situations?
In terms of treatment, as we've already heard, there are different options for treatment of opioid use disorders. So medication-assisted treatment, you know, the methadone and the Suboxone, we tend to hear about the wait lists. But when it comes to other treatment, you know, whether it's a detox followed by counseling, there typically is capacity in our community. And I would encourage, as Jeremy already pointed out, to contact a treatment provider, start the assessment process, and we are working with people to help you get connected to services.
I would would also add that you think about it, if your approach is that someone needs to be given the drug lifelong, you're not going to open up many treatment spots. That's why at Upstate we don't do that. We average 10 visits per person. If you have a teenager, we start seeing people at 12. We train the child fellows. You must bring in a support person that's usually a member of your family. So if you were 14, you'd come with your parents and we'd all talk together about what to do. So the amount of treatment you get is what affects the waiting list.
We'll take one more, Matt.
Sure, and before I ask this next question, just a reminder, if you need an index card, you need a pen. Again, we're taking these questions and comments from you, and we're not just answering them here, we're going to be using those for other purposes. So please do write down your questions or concerns. This one might be directed toward our physicians. What's being done to educate doctors about prescribing narcotics?
Good question.
Well, it so happens that yesterday I went to a very nice talk given at Cross Hospital by a pain specialist. And he was educating the doctors on the overuse of pain medications. That was a very enlightening presentation for me as an addiction specialist. I also want you to know that there are many regulations in place before you get a license to be able to prescribe Suboxone. You need to have a certain treatment, treatment exposure hours in order to get a license. The problem that I have now is that I have a maintenance treatment clinic. I mean, I don't tell the patients, you're going to be here with me for about 6 months, and then at that time I'm going to be discontinuing the medication for you. You're going to withdrawal, and goodbye. I tell them, when you're ready to start going down, then we're going to, go down gradually in order for you to suffer as less as possible. Before I start a patient on Suboxone, I tell them that this may be kicking the can down the road. It is an opiate. And if we start you on Suboxone, and then there comes a time for you to decide, I want to get off Suboxone, you're going to be experiencing withdrawal. You're going to be experiencing withdrawal. So I want you to think about it. Okay? Now, the population that I have is a selection bias, because I do have many people that come from the legal system. Some of you may think, well, that's a difficult population to treat. I have to tell you that that's an excellent population to treat, because I have the leverage of the judge.
Right.
Either you come and see me, or you're going to be going back to jail. And then they come. And I cannot tell you how satisfying it is for me to see young people, unemployed, having difficulties with the law, slowly gaining employment, moving on with their life, getting married, having children, and then telling me with a lot of pride, doctor, today is my first year, second year, third year of sobriety. I cannot tell you how satisfied, how much satisfaction I get from seeing this patient at the Suboxone clinic. I know I went on a tangent related to the question.
Thank you, Dr. Biaggi.
But that's
Thank you very much. Actually, we will be hearing more about the physician role in our next panel discussions. I'd like to thank our panelists. We have 4 programs represented here right now, but I want to remind the audience that we have the majority of our treatment programs that are based here in Onondaga County. Informational tables are right out in the foyer area. Please feel free to grab information. We do have a 3rd panel coming up. I'd like to invite Dr. Gupta up for the 3rd panel. Thank you.